Welcome to AETCM, the emergency medicine channel.
Yes.
Present the case of a 50-year-old male who came to ER with complaints of fever, cough, and breathing difficulties since last 3 days. On initial 10-second assessment, the patient was conscious, oriented. He was able to talk in full, complete sentences. On initial 10-second assessment, the patient airway was patent. There was no pooling of secretions or stridor. Breathing-wise, the patient had a respiratory rate of 28 per minute, with a saturation of 81% in room air, and on auscultation, they had bilateral basal Krebs was present for this patient. Following the saturation of 81% in room air, we had initially kept the patient in a propped up position, and also we had initiated on oxygen by O2 mask. Following which we are also checked the circulation wise. The patient had a BP of 110/70 millimeters of mercury, with a pulse rate of 82 beats per minute and a capillary refill time more than 2 seconds. And disability wise, the GCS was E4 V5 M6 and GRBS was 90 milligram per deciliter. And exposure wise, the temperature was 100 degree Fahrenheit, and there was no presence of any rashes along the body. And along with the following the temperature of 100 degree Fahrenheit, we had initiated on an antipyretic injection paracetamol. 1 gram IV stat was also given for this patient. Following which we had again reassessed the breathing part. The patient was again tachypneic. The patient had a respiratory rate of 28 per minute, and the saturation had improved post giving oxygen to 94 in room air. And we had taken as an adjunct to the private survey of CBC-CRP point of care, and ABG was taken with ECG. So in point of care, it was showing a total counts of 900 with an absolute neutrophil count of 420. So and HB of 4, platelet count of 5000, and CRP of more than 170. So and also an ABG wise, the patient had a type 1 respiratory failure, and along with that, the patient had a pH of 7.305 with PCO2 of 34, and BO of 56, lactate of 4, and a creatinine of 1.2, and bicarbonate of 20. So the patient was showing features of type 1 failure with increased respiratory rate. So we had initiated him on NAV.
Okay.
And
what is there in your mind when you are starting NAV?
So initially, it's we have to rule out whether patient is showing features of any pneumothorax. So that's first need to rule. We have to rule out.
Why pneumothorax?
When patient comes with sudden onset breathing difficulty, we have to initially rule out whether patient is having any underlying.
What is the basic history to think about pneumothorax?
We should always ask about any primary lung pathology is there.
This patient, why did he think about pneumothorax?
Like before starting NAV, we have to rule out.
Okay, before starting NAV, you have to rule out. That is okay,
yeah.
But why did you suspect pneumothorax?
No, just to rule out. No, yeah, just before starting NAV, we started. And so we had initiated on NAV, and then we had the HB was 4, so we had arranged for 4 units PRBC.
Okay.
And also
HB is 4. What are the differential diagnoses you think in this patient who is having breathlessness?
Yes. So in this patient, we came to a primary diagnosis that patient could be having an anemic heart failure.
Cardiac failure.
Anemic cardiac failure. So that was the primary diagnosis which we came into. The patient had an underlying fever episode. Fever spike was there with a temperature of 100.
Temperature is normal.
100 degree Fahrenheit.
100 degree Fahrenheit.
So this patient had 100 degree Fahrenheit with a neutropenia.
Okay.
So we came to a diagnosis that patient.
What will happen to temperature status in a patient with neutropenic sepsis?
Neutropenic sepsis, if the patient shows features of shows blood counts with neutropenia, and if there's features of fever,
we know that it is an infection.
Yes.
Normally, in a severe neutropenia, what will happen to your body temperature in case of an infection? There may be normothermia or hypothermia
also.
Okay.
Yeah.
We don't expect a high temperature in a neutropenic patient because there is no cells are there to produce a reactive change against bacteria or virus, whatever it is. So you have to be very careful in a patient with neutropenia Fever may not be there in sepsis.
And we are arranged for 4 units RDP and or 1 unit STP. Following which we had corrected the sample history of this patient.
Okay. How do you give blood transfusion in this type of patients?
In this type of patients, we must make sure the patient will be in a volume overload state.
Okay. Mostly patients are in volume overload condition.
Yes.
So how do you transfuse?
So in this individual, we had initially checked the volume status of the individual. Initially, we did a focused ultrasound. In that, it was showing diffuse B-lights along all lung fields. Along with the patient had a the IVC was distended. So along with a good LV function.
Okay.
So we came to a diagnosis that patient is having a circulatory overload.
Okay.
So most probably due to the anemic underlying heart failure is what we came to the conclusion. So in such individuals, we should give a underlying antidiuretic, like diuretic.
Diuretic.
Must we give a diuretic cover along with blood transfusion.
Okay. So you have to give a slow transfusion and under the cover of diuretic. Okay.
So
which condition you transfuse whole blood? Here all you transfuse packed cells. Which condition you give a whole blood fresh whole blood transfusion is useful in which all conditions? It may not be available always. Trauma is the one condition where if possible, whole blood is ideal. Okay.
Yes.
Otherwise, you have to give multiple components. Yes. Since it is fresh blood is nowadays not available, we all give components.
Yes. So we had taken a sample history for this individual. The patient was a 50-year-old male. He was a known case of aplastic anemia. So he came to ER with complaints of fever, cough with breathing difficulty. The patient initially had a dyspnea on exertion grade 2. In the initial, it was there since last 1 week. So it initially developed as a dyspnea on exertion grade 2, then now progressed to a dyspnea on exertion grade 4 since today. And no history of any chest pain or there was history of palpitation was present for this individual. No history of orthopnea and PND was also present for this individual since last 2 days. There is no history of any vomiting or loose stools or dysuria. There is no presence of any there's no presence of any hematuria or any passage of blood in stools, like bleeding PR, or no history of any melena hematemesis. No history of any altered sensorium for this individual. No history of any disorientation. Following which, we are also asking the allergic history. The patient was not allergic to any medication. We had asked in the past medical histories, medication history. He was on L-Trombopac. So
L-Trombopac is used
in case of this platelet, low platelet.
It was basically used in ITP. Then hepatitis C induced thrombocytopenia. Now they are using in most of the thrombocytopenias.
So the patient was on L-Trombopac, 50 mg OD dose.
Thrombopoietin.
Yes.
They are called as
thrombopoietins. And he was also on cyclosporin. So cyclosporin, he was taking at a dose of about 30 mg he was taking per day. So he was taking orally in 2 divided doses he was taking. And past history, he is a known case of aplastic anemia, and the last meal was about 2 hours back. So we are again examined the patient. The patient on examination was conscious oriented, chest wise. There was bilateral basal pulse was present, and CVS wise S1 S2 was present along with an ejection systolic murmur.
Okay. What may be the reason for ejection systolic?
So we came to a conclusion that it could be a flow murmur. So
hemic murmur. Flow murmur, but it is called as hemic murmur.
So most probably due to the anemic heart failure. And following which,
if anemia is not there, what else you suspect in this type of patients? Those who are on anti-malignancy drugs, they are getting a new murmur in the heart with fever.
endocarditis.
There you have to suspect endocarditis. Here it is only flow murmur.
Following examination, we came to a provisional diagnosis that the patient has a severe aplastic anemia with the anemic heart failure and neutropenic sepsis.
Okay.
So that was the final conclusion we got into. And then we had sent for the labs. The patient had a lab total count of 900. With an absolute neutrophil count of 430.
430.
Yes,
severe neutropenia.
Severe neutropenia, along with a platelet count of 5,000.
Okay.
And CRP was 300.
Why even at 5,000 patients are not bleeding?
vital function is preserved.
Even if the numbers are less, function is preserved, and most of them are fresh platelets. Okay.
Yes, but the patient had an HB of 4. So the patient previously, about 2 months back, the patient had an HB of 6. So there was a slight drop for 6 to 4. So considering the drop, we we arranged for blood already. So we had transfused 2 units PRBC.
Okay.
Under injection Lasix.
What are the complications of blood transfusion in ER?
In blood transfusion, there are major it could be the febrile
febrile episodes.
Secondly, is usually circulatory overload can also TACO or TRALI, transfusion to circulatory.
What is the difference between TACO and TRALI?
TACO is usually circulatory overload. So
other one?
Lung injuries.
So both will produce pulmonary edema. One is actually volume overload pulmonary edema. Other one is lung injury induced pulmonary edema. Okay, one takes time. Other one is immediate.
So with this patient, we had initiated PRBC transfusion under Lasix cover, and also we had initiated for unit RDP transfusion also. Since patient had a platelet count fully 5,000, and we had also given dexamethasone 4 mg.
Why dexamethasone?
In cases of aplastic anemia cases, steroids are helpful in the case of severe aplastic anemia. And we had given a hematology consult for this patient, and they had initiated on anti-thymocyte globally. Okay. It was at a dose of 40 mg per kg per day IV dose into 4 days. So they had given a stat dose. And it was also done under corticosteroid, the dexamethasone cover we had given. For this patient. And
so what antibiotic you prefer in this type of cases? You have a patient who is having severe neutropenia and mild fever, and you are suspecting sepsis. Neutropenic sepsis. What antibiotic prefer from ER?
So we should have a broad spectrum with the Pseudomonas cover. So
what are the drugs has got Pseudomonas cover?
Piperacillin tazobactam we can be preferred at the minimum, or we can go for meropenem. But or carbophenams.
What is a dual drug therapy for Pseudomonas? Dual drug therapy. Have you read about that? So in a severe neutropenic sepsis with Pseudomonas, ideally you have to give 2 drugs. One is like you told, piperacillin tazobactam, carbapenem, and one more drug you have to give. That may be preferably another gram-negative coverage. So 2 tobramycin, quinolones, something like that. So dual drug therapies are always better if you have proven. In emergency room, single drug therapy can be started. What else you cover other than Pseudomonas? Any gram-positive cover?
Yeah, we should also look for
MRSA. So ideally 2 drug combination has to be started from ER. Then later after culture report you can discontinue it. What are the other viral infections which can present in this type of cases?
This patient can undergo herpes.
Viral, so many viral fevers can be there. Which virus can inhibit the parvovirus? That also you should keep in mind. Parvovirus attack can further worsen the situation. Like you told, any virus can produce like herpes. What else you told? You told something. Cytomegalovirus. So many viral infections can be there.
Following which the patient was admitted to ICU, and following we had the blood culture was also taken. Blood culture showed Pseudomonas aeruginosa, which was sensitive to piperacillin tazobactam. So there was continued on that antibiotic. And during the course of the hospital, the patient had subsequently improved, and the counts had increased following giving of the medications, and it increased around 2,000, and they were discharged from the hematology center. So we came to in aplastic anemia. Usually there are 2 types of aplastic anemia. So that's usually immune-mediated or idiopathic aplastic anemia, or an acquired aplastic anemia. So the acute aplastic anemia is usually defined as a pancytopenia with hypocellular bone marrow, without any abnormal infiltrates or fibrosis in the bone marrow. So it is usually by the suppression of the hematopoietic stem cells or the progenitor cells. So the pathology is usually that it must be like clinical pathological finding is that there must be a cytopenia in at least more than or equal to 2 blood lineages. So that is, there must be anemia or thrombocytopenia with neutropenia, and bone marrow hypoplasia must also be present. So there is a severity grading for aplastic anemia. So in severe aplastic anemia, in the bone marrow cellularity will be less than 25%, and peripheral blood smear with show absolute neutrophil count less than 500, and platelet count is less than 20,000, and also reticulocyte count less than 60,000.
Here it is severe.
Yes, in this patient had a severe aplastic anemia. And very severe aplastic anemia is also there. In very severe aplastic anemia, they are showing features of, bone marrow shows features of severe aplastic anemia, like cellularity of less than 25%, with the absolute neutrophil count of less than 200 per microliter. Okay. So this patient had a severe aplastic anemia. And non-severe aplastic anemia is also there. In that, the bone marrow criteria is same as severe aplastic anemia itself, but the peripheral cytopenia shows counts more than 500. Okay. Absolute neutrophil count will be more than 500. So that's the difference between severe, non-severe, and
there are other entities like myelodysplastic anemia, myelothysis anemia. They all mimic aplastic anemia. But treatment-wise, these all the whatever you have done is the same treatment what we can do in emergency room.
Yes.
A lot of other treatment options are available.
Yes. So usually the causes mainly involves immune mediated. So immune mediated is actually Treg cells overactivity. So that can cause increased destruction of the bone marrow cells, and also acquired is usually by cytotoxic drugs or radiation of chronic cancer treatment, or drug reactions usually like in anti-seizure medications like carbamazepine, phenytoin, and antibiotics like sulfonamides and chloramphenicol also can precipitate acquired aplastic anemia. And NSAIDs like indomethacin and phenylbutazone, and antithyroid medications like propylthyroxine, methimazole, and gold or arsenic, and chemicals like benzene also can precipitate. Viral infections usually involve Epstein-Barr virus or hepatitis, seronegative hepatitis, and also HIV and parvovirus B19 infection. And immune disorders, SLE or graft versus host disease is precipitating factor. And usually the
methotrexate, one of the common drugs, bone marrow suppression mechanisms are different, but methotrexate is one of the common drugs what we see in the practice. Yes. In a rheumatological center or even in anti-cancer, but they give folic acid, folinic acid to counter that. There it is a anti-folate drug.
So, So in aplastic anemia treatment, there is actually different criteria. So we should first check whether the patient is having severe aplastic anemia. So severe aplastic anemia, as said before, the patient should have a reticulocyte count less than 6,000 per microliter, or a platelet count less than 20,000, or absolute neutrophil count less than 500 per microliter. If it is,
what are the clinical uses of reticulocyte count for an emergency doctor?
So reticulocyte count is a factor which will help us to know whether the bone marrow is producing the cells or not. Anemia also we can
for an ER doctor, why it is important? Anemia is a different issue, different problem. Here, why you are using all these things?
So you can understand whether there is myelosuppression or so with hiking up the antibiotics.
Every day we are seeing cases now. Reticulocyte count is very high. It is low. Hemoconcentration, what will happen? It will be very high. So in acute trauma, acute volume loss, hemoconcentration, reticulocyte count will be higher than normal. So that is the most important thing for you. For anemia and evaluation, that is a different issue.
So if these 5 factors are present, we check the ECOG performance status. There is a criteria for the individual. So 0 is fully active. 1 is that patient has a restriction of strenuous physical activities. Okay. And 2 is capable of all physical activity, but he is up for more than 50% of the time during the day.
That is because of anemia.
Yeah, anemia, the performance status. In grade 3, it is the patient is capable of only limited self-care and is confined to bed for more than 50% of the time during the day. And bed 4 is completely bedridden. So if the patient is having this ECOG criteria grade more than 2, then we should individualize the therapy. So we should initially start with low intensity immunosuppression like cyclosporin A. So cyclosporin A is the initial treatment. Along with that, we should give a TPO agonist like L-thrombopac also. And the supportive care involves transfusion. If the patient is not having any such features, then we check the age of the patient. If the age of the patient is less than 40, if it is less than 40, we can he is a candidate for a like hematopoietic stem cell transplant in a later stage. If it is not is more than 40 years, then he should go for a triple immunosuppressive therapy, which is usually the anti-thymocyte globulin antibody. So that is the initial treatment along with cyclosporin A and L-thrombopac. So this individual patient was more than 40 years of age with a ECOG status of more than 2.
Okay.
So that's why he was started on anti-thymocyte antibody and he was also started on L-thrombopac.
Okay.
And then his condition had improved.
If chronic, this patient may require chronic blood transfusion. What side effects he can develop because of chronic blood transfusion, repeated chronic blood transfusion?
Iron overload is one.
So iron overload is one of the side effects.
Yes.
That also you should tackle. Okay.
Yes.
Anything else?
Hemocysteine deposition.
Deposit. That
Can
can
go into hypocalcemia. Hypocalcemia.
Hypercalcemia.
Yeah.
Okay. Stored blood transfusion can produce hypercalcemia. Anything else? Okay. Thank you.